Welcome everyone to StayCurrent Surgical Forum, where today we have one of my dear friends, Dr. Nat Soper, who's the professor and chairman of the Department of Surgery at the University of Arizona College of Medicine at Phoenix. Nat has been a pioneer in laparoscopic minimally invasive surgery and foregut surgery, and he actually taught me how to do laparoscopic cholecystectomy probably in 1990, a few years back. And that has refined the procedure and taught it to so many throughout the world. So Nat, thanks for being here today.
Well, thanks for having me, Jeff. It's a real pleasure.
So you think it's a pleasure, but right now what I'm going to do is to ask you how to perform a lap chole. How easy could that be? But let me tell you about a patient that you may see. She's a 48-year-old woman who's a little bit heavy. She weighs about 180 pounds, and she is type 2 diabetic, and she comes to you because she's had multiple attacks of right upper quadrant pain, and the ultrasound shows that she has a thickened gallbladder wall and gallstones. And so you set her up for a lap chole, and you bring her in the OR, and you review everything before you do it, and you take her in the OR, and they put her to sleep, and your residents prep her abdomen. And she's all draped, and you go up to the table, and you examine her abdomen, and what you feel is that in the right upper quadrant, there is a fullness. There is somewhat of a mass in the right upper quadrant. Does this change what you're going to do?
No, I don't think so. I mean, it sounds like she's going to probably have a very chronically inflamed gallbladder with a bunch of omentum stuck to it. That would be my bet.
Where are you going to put in your ports? Where do you do that?
Well, I'm going to put my initial one down at the umbilicus, where it should be well away from anything that's going on in the right upper quadrant.
How do you do that now? What approach do you do at the umbilicus? You do Hassan, or what do you do?
So if a patient is not obese, I will do a Hassan. In patients with a BMI over about 32 to 35, where you would require a fairly large incision to do a Hassan, then I will do a varus.
Okay. You don't use the OptiView in these patients at all?
I don't. I've seen a couple of terrible complications when people have used that. And so I'm old school.
Yeah, so am I. All right, so you get in with your first port. You can see the right upper quadrant's got a lot of momentum in there. You put in the other ports. Just tell me quickly where those other ports are.
Well, usually one is in the epigastrium, and it angles just above the falciform coming across, and then the two in the right upper quadrant are in usually the mid-clavicular line and then the anterior axillary line, something like that.
All right.
And I always put in the epigastric one last because that's the most important one in terms of your angle getting at the gallbladder.
Okay, that's your operating.
The surgeon's right hand. Yeah.
All right, so you get in there and you're right. The omentum is stuck. You can't even see the gallbladder, but you see the edge of the liver with omentum stuck there. How do you take that down?
Well, this is the kind of thing that we see actually fairly frequently. And some of the hardest cases are the ones where you can't even find the gallbladder for half an hour or something, And so it's time consuming. It's a pain in the butt, but essentially what you have to do is, grab the omentum and usually just using cautery, but sometimes I've actually brought in harmonic shears or something to help with this because it can get a little bloody. But usually if you get right at the junction of omentum with whatever else and exert some traction there and a little bit of low wattage cautery, you can usually start peeling this back until you can find a little bit of the fundus of the gallbladder, because that's really the key, so that you can then grasp that and elevate it so you get counter traction on it.
Okay, so you start taking this down. At what point do you know that you've taken it down enough?
Well, I mean, I think you need to take it down as much as you can, because otherwise it's going to be tethering that right lobe of the liver and make it really hard to expose. So I certainly take it down until it's off of the gallbladder, off of what I consider would be the area of the cystic duct and cystic artery, to get it away from there.
So you get down to the infundibulum, you get below the infundibulum, and now you start to do what? How do you work at that point? You've got it exposed. What do you do?
Right. Well, again, what I tell the residents is we're going to do a modified top down, but only start about a third of the way up from the bottom. Okay. And so I try and get right on the wall of the gallbladder and go back and forth from medial to lateral what the French used to call waving the flag. And so you can actually get a good three-dimensional view looking at it from both sides. And obviously this would be an angled laparoscope. I can't understand how some people still use 0-degree laparoscopes, but I think the angled scope really helps. And dissect right along the gallbladder wall down toward the infundibulum.
Okay.
And then obviously what we're going to try to achieve before doing, anything irreversible with clips or cutting or anything else is to see the critical view of safety.
Okay, so let's stop there a minute. I love the fact that you're doing a dissection up high first, both sides getting even. Do you get all the way around the gallbladder, or you just sort of take both sides down a little bit?
Take both sides down. I like to actually keep it symmetrical.
Okay.
I see a lot of the trainees who just stay on the left side of the gallbladder, the ventral side of the gallbladder,
Yes,
for 99% of the dissection. I think that really hurts you. I think if you get it from the lateral side as well, you get lots more freedom on that gallbladder to be able to dissect underneath it and be able to move it around. Yeah.
You wave that flag. I love that analogy. And you're taking it down. And at this point, Nat, what happens to me is that all of a sudden everything looks fused there. You can see where you think the cystic duct is and the cystic artery, but it looks like a single piece of thick material. What do you do there? How do you dissect it out?
Well, one thing I like to do is to actually do intraoperative ultrasound.
Oh, good. Okay.
And so in a tough case like this, I'll often actually do it multiple times. Once at the beginning of the operation to get an idea where the gallbladder is in this particular patient. But at this point, if it's really hard to do the critical view of safety safely, then an ultrasound can show you where the gallbladder ends, where the bile duct is in relation to where you're dissecting.
How do you separate that tissue? Do you use a Maryland, or do you use suction?
Again, I don't think that there are any real tricks to this, Jeff. I mean, it's a lot of traction, counter traction. I actually use a lot of what I call irrigation suction Kittner dissecting. So blunt dissecting, there's usually a fair amount of blood by this time. Often you put a hole in the gallbladder and there's bile. It's hard to see anything. And instead of getting a whole bunch of Kittner dissectors, I'll just get my suction aspiration catheter and use that in my right hand, my dissecting hand, to really push again right along the gallbladder wall as much as you can to get things separated.
I didn't mention it. Have you used indocyanine green at all to identify the biliary structures?
I have used it some. I've had trouble getting patients in early enough to give it early enough. So everything is just bright green usually when I get in there. And in a case like this, I've had one not dissimilar to this where, given the tissue characteristics, you really can't see much in regards to the duct. So I have not been really impressed with ICG, but I know a lot of people who have been and use it on a regular basis.
All right. So you're dissecting here and you've got what you think is the cystic duct. And what you think is the cystic artery next to it. It's not perfectly defined, but there's a little bile hole right near the gallbladder, where you think is the cystic duct junction. What do you do for that?
You say there's a bile hole?
There's a hole draining bile, a little tiny hole that's draining some bile right up there.
So does it look like it's coming from the liver or?
No. It's on the ductal structure as it seems to go into the gallbladder.
Okay. Again, I would make sure I've dissected out the critical view of safety. So all of that fatty material, all of that peritoneal stuff, all of the scar tissue holding that neck, the infundibulum of the gallbladder into the liver has been divided. So the gallbladder is, now 1.5 inches away from anything around it.
Okay.
And if then that should prove then whether this is cystic duct or not. If it's cystic duct with a hole in it, there's no big deal. I might put a catheter down, do a cholangiogram just to prove it.
You know what I was trying to get you to do.
Right, just to prove that that's what it is. But, you wouldn't necessarily have to, again, if you've dissected it all out. If you have not dissected it all out, then you absolutely have to do a cholangiogram so you can get a better idea of what that ductal structure is.
So if they're having trouble getting a good critical view, then they can use that little opening to do a cholangiogram.
Yes.
Okay, very good. Well, you've got it dissected out and you're happy with what you've got. And what would be your indications to do a cholangiogram in this patient?
So I actually believe in a couple of things in the lap chole religion wars. One of that is that everybody should know how to do cholangiography. So in a residency program, I think we ought to do them very frequently, regardless of indications. Likewise with ultrasound. I love teaching residents how to use ultrasound in the laparoscopic abdomen, because you can only see the visible surfaces, and the ultrasound lets you see beyond those visible surfaces. The reality is that cholangiograms do add time, they do add money, and the majority of the time they're not absolutely necessary. So I can certainly understand why people would be selective cholangiographers.
What are your criteria? What would you do? Just give me a list.
So the criteria would be uncertain anatomy, number one. Number two would be so the other thing that I do routinely is, before I clip and divide the cystic duct, I'll put a clip on the stay side up on the gallbladder and make a little incision in the cystic duct and milk it backwards to see if there are stones in the cystic duct.
And then you would do a cholangiogram.
If there's stones in the cystic duct, in our experience, that's one of the prime things that will show you that there probably are common bile duct stones too. So cystic duct stones means cholangiography.
Patients had jaundice, you might do a cholangiogram also?
Oh, jaundice, dilated bile duct on preoperative ultrasound. So if you have a relatively medium to high concern about bile duct stones, or if the anatomy is unclear, you have to do a cholangiogram.
All right, so you do all this and everything's good, and you put your clips on and you divide your gallbladder and you take it out. How do you take it out of its bed?
I just use low wattage cautery, and again, a lot of traction on the gallbladder. So the other thing that happens with these gallbladders that you've just mentioned in terms of the degree of chronic inflammation, they're usually intrahepatic. There's no plane between the gallbladder and the liver. And in those patients, I do what I tell the residents is called controlled avulsion. So left hand, a lot of traction on pulling the gallbladder away from the liver. Right hand, just barely touching that junction of gallbladder with liver with low wattage cautery, and essentially carve it out of there.
So you've got it out. You've got it out. You've got it out intact, and there's some oozing from the bed. What do you do for that?
Well, usually start with just cautery. So I'll put a suction, irrigation suction thing in my left hand. I'll do this before I completely take the gallbladder off the bed, so that the assistant can be holding up the right lobe of the liver with that remaining bit of gallbladder. Left hand, then, with an irrigating suction, you can suck the smoke, you can suck blood or whatever. Right hand with a cautery, and just touching the areas that are bleeding. And 99% of the time, you can get it stopped.
So if you see a dot of bile in the middle of the bed, what do you do? Just a dot.
So if it's clearly in the middle of the bed and everything else you've done has shown you that you knew the ductal anatomy, then, I mean, if it's tiny, I mean,
this could be a Luschka duct, for example.
Right. So if it's a Luschka duct, I would probably try to put a stitch in it, a small stitch. But the likelihood is that's not going to hold anyway, so I'd put a drain in. Likewise, if I was deep into the bed in one of these intrahepatic gallbladders, I will put a active drain in and leave it in, at least for several hours if we're going to try and send them home, or usually keep the patient overnight and just make sure there's no bile in there.
So as we come to a close, I want to ask you, is it your intention to send most of them home the same day?
Absolutely. 95% go home.
Do you give the patient any special medication to relieve pain, either intraoperatively or postoperatively? What do you do?
Well, the anesthesiologist will usually give them we usually use IV Tylenol, which I think works pretty well. We'll send them home with 5 hydrocodone tablets or something like that, but only 5, and tell them if they need more than that, they need to call. But I just tell them to go ahead and take either ibuprofen or Tylenol in addition to that for the first few days. If they have more pain than that, there's a problem.
I want to say thank you, Nat. You know, it's good to know that you're still doing what you taught me and that you can still take out a gallbladder. I'm done taking out gallbladders. I'm retiring now. But all I can tell you is you'll always be my hero. And I thank you so much for doing this with us today.
Well, and Jeff, I've got to say, in return, you're a hero of all of us endoscopic, laparoscopic surgeons for what you've done for the field. And so it's been so much fun being able to hang out with you over the last 30 years since we've been doing this laparoscopic stuff. So anyway, thank you for including me in this series.
And I'll see you soon. Thanks, buddy. Bye-bye.
Take care.